So there are various concepts proposed to attain the balanced occlusion. One of them is very important, articulation quint, given by Hanau. Rudolf L. Hanau proposed these 9 factors that governs the articulation of artificial teeth. They are horizontal condylar guidance, compensating curves, protrusive incisal guidance, plane of orientation, buccolingual inclination of tooth axis, sagittal condylar pathway, sagittal incisal guidance, tooth aligner, relative cuspal height. These 9 factors are called laws of balanced occlusion. But later Hanau condensed these 9 factors and formulated 5 main factors, which are: first one is condylar guidance. Second, incisal guidance. Third is compensating curves. Fourth is relative cuspal heights. And fifth one is plane of occlusion. Just remember, previously there were 9 factors. Now they are condensed into 5 factors, right? Then there are various factors influence the balanced occlusion. The important are condylar guidance, incisal guidance, plane of occlusion, cuspal inclination, and compensative curves. There should be balance within these 5 factors, right? The incisal and condylar guidance produce a similar effect on balanced occlusion. They increase the tooth separation. These two, they increase the tooth separation, right? Similarly, the other 3 factors have a common effect on balanced occlusion. They decrease the posterior tooth separation, decrease posterior tooth separation. It increases, right? The effect of incisal and condylar guidance should be characterized by the other 3 factors to obtain balanced occlusion. If this counteractive mechanism is lost, the balance of occlusion is lost. Let us discuss them one by one. First is your condylar guidance. In the diagram, you can see here, this is your articular eminence. And this is your condylar guidance. So what happens when patient protrude the teeth? When there is protrusion, there is separation of posterior teeth, right? If this articular eminence is steep, then condyle will move like this, and there is more separation of posterior teeth. If the articular eminence is less steep, then condyle will move like this, and there is less separation. That means shallow condylar guidance, there is less separation. So we need shorter cusps and flatter fossa. In case of steep condylar guidance, to compensate the separation, we need longer cusps and deeper fossa. So basically, the condylar guidance is mandibular guidance generated by the condyle and articular disc traversing contour of glenoid fossa. Condylar guidance is due to path followed by the condyle in temporomandibular joint, and it is mainly obtained by protrusive movement. And while protrusive movement, we have to register the record. This is the first factor of occlusion. So this factor, we cannot change this factor. So according to this factor, we have to manage the cuspal heights without compromising the phonetics and functional nature of teeth. The incisal guidance should be decreased due to reduced amount of jaw separation. It should be remembered that the incisal guidance cannot be made very steep because it has its own ill effects, right? Then come to your incisal guidance. Like your condylar guidance, and incisal guidance is a second factor of occlusion. So it is determined by the dentist and customized for the patient during anterior trying. It acts as controlling path for the movement of cast in and articulator. It should be set depending upon the desired overjet. This is your overjet and desired overbite, right? If the overbite is increased, the incisal inclination increases. During protrusive movement, the incisal guidance, incisal edge of the mandibular anterior teeth move in a downward and forward path corresponding to the palatal surface of upper incisor. This is known as protrusive incisal path. See, there is an angle, incisal guidance angle formed between the angle formed by the intersection of plane of occlusion. This is the plane of occlusion and the line with the sagittal plane determined by the incisal edge of maxillary and mandibular central incisor when teeth are in maximum intercuspation. So angle formed by during this movement. This is your incisal guidance angle. Right. This influences the shape of the posterior teeth. If the incisal guidance is very steep, that means steep incisal guidance, more separation of posteriors, then we have to provide longer cusps and steep occlusal plane and compensating curves. That means if the incisal guidance is steep, steep cusps or steep occlusal plane or steep compensatory curve is needed to produce balanced occlusion. In complete denture, the incisal guidance angle should be flat as possible. Hence, while arranging the anterior teeth for aesthetics, and a suitable vertical overlap and horizontal overlap should be chosen to achieve balanced occlusion. Also, the incisal guidance cannot be altered beyond limits. The location and angulation of incisors are governed by various factors like aesthetics, phonetics, and function. We have to change the incisal guidance according to these three factors, right? The procedure for setting up the incisal guidance was described under articulation in the previous videos. Now come to plane of occlusion. So what is plane of occlusion? It is the first factor which compensate the tooth separation while protruding the teeth. It decreases the posterior tooth separation. So it is an imaginary surface which is related to anatomically to the cranium and which theoretically touches the incisal edges of the incisors and the tips of the occluding surface of the posterior teeth. It is not a plane in true sense, but represents the mean curvature of the surface. Like if this is your arch, it starts from canine area up to from canine area up to retromolar pad. We can alter it up to 10 degrees, right? Suppose it starts from here up to this area. So this is basically the straight line, but we can alter it to up to 10 degrees, right? So anteriorly, it starts from canine and posteriorly up to retromolar pad. It is usually parallel to ala tragus line or Kemper's line. While making denture, we mark it on the face of the patient. One mark on ala of the nose and second on the tragus. Then we used to meet them and follow them for the curvature. There are various curves. First is your curve of Spee. It is the anatomical curve established by the occlusion alignment of the tooth as projected onto the median plane, beginning with the cusp tip of mandibular canine and following the buccal tips of the premolar and molar, continuing through anterior border of the ramus of mandible, ending with the anterior most portion of the mandible condyle. Here in the picture, you can see it starts from this area. While doing the teeth setting, this curve starts from canine, from the buccal, from the tips of the premolars, and we have to follow the curvature of the ramus up to the condyle. According to this curvature, we have to plan for teeth setting so as to maintain the curvature of the curve. This is called curve of Spee. Compensating curve for curve of Spee in artificial dentition is anterior posterior curve. Just remember this. It is anterior posterior curve. Posterior teeth set on this curve will continue to remain in contact during protrusion. So it is the second factor which compensate for separation of teeth. Compensation. Right? Suppose when there is a protrusion of the protrusion of mandible, then if this curve is placed in the artificial dentition, then while moving our teeth forward, this curve will compensate the separation of posteriors. Right? Then come to a curve of Wilson. Wilson curve is defined as a curve of occlusion which is convex upward. See, it was given by George H. Wilson, and it is a mediolateral curve. Contacts buccal and lingual cusp strips of mandibulars on each side. This is see this picture. This curve moves like this. So it is a, suppose if we are doing teeth setting in upper and lower, and if this curve is not maintained, while lateral excursion will not able to pressure of non-working side. So to compensate the separation of this, we have to maintain this curve. You can see this curve moves like this, right? The curve runs opposite to the direction of the Monsoon curve. Okay. This curve followed when the first premolars are arranged. The premolars are arranged according to this curve so that they do not produce any interference to lateral movement, right? While premolar teeth arrangement, right? Monsoon curve is the curve of occlusion in which each cusp and incisal edge touches or conform to the segment of spear of 8 inches in diameter with its center in the region of glabella, which I discussed in last slides. In mandibular arch results from inward inclination of lower posteriors, as we all know. making lingual cusp lower than buccal cusps. Curve begin concave. In maxillary arch, see this. This is your. If this is your mandibular arch, we can see it anterior posteriorly, right? So there is some inclination of tooth inside, so that this curve maintains like this. And for maxillary, outward inclination of to compensate this inclination, there is outward inclination of maxillary. We can very well imagine. So it is convex towards lower side and concave towards upper side. Teeth set on this curve will have lateral balance of occlusion, as I've already told you. Then come to a concept of non-balance occlusion. So what is the concept of non-balance occlusion? The concept of monoplane occlusion was a result of Shepard's statement, interbolus exit balance, which we already discussed. Consecutively, many clinicians came with a different concept of non-balance occlusion for complete denture. So in non-balance occlusion, Pound's concept was that he proposed a monoplane occlusion which stresses the importance of phonetics and aesthetics for anterior teeth. The posterior teeth, on the other hand, have a sharp upper lingual fossa and a wide lower lingual fossa. The buccal cusps of the lower posteriors are reduced to avoid non-vertical occlusal forces. Effectively, it was lingualized occlusion, wherein there is no balance contact of upper and lower teeth, and occlusal surfaces are reduced such that they lie in a triangle forms between the mesial end of the canine and two sides of the retromolar pad. Like we can discuss over here, like in Pond's concept, the teeth arrangement, like if this is your upper arch, this is your lower arch, this is maxillary arch, and this is mandibular arch, so that there is no interference while lateral excursion. It is also called monoplane occlusion. We'll discuss it in later slides. Okay. Then, so what is occlusal form? In occlusal form, we can make buccolingual inclines up to 33 degrees of anatomic teeth for patients with strong, well-formed ridges. That means we can make it up to 33 degree. Beyond that, we'll feel interferences. And 20 degree buccolingual inclines. Just imagine 3D buccolingual inclines of the semi-anatomic teeth for patient with rich contour is reduced by resorption. And non-anatomic teeth, they are 0 degree. Non-anatomic teeth patients with flat ridge and knife ridges, so that he or she will be able to maintain the occlusion while lateral excursion, while protruding and all. Right. So according to this concept, the anteriors are set by aesthetic and phonetics. Requirements of the posteriors are set up with vertical overlap such that there is disocclusion due to canine during eccentric movement of the mandible. Right. Then come to your lingualized occlusion, which is very important. It was given by Geissy in 1927. So what is lingualized occlusion? This type of occlusion involves the use of large upper palatal cusp against a wide lower central fossa. Right. In the picture you can see. Right. In this scheme, the buccal cusp of the upper and lower teeth do not contact with each other. Clow reported 67% of the patients preferred lingualized occlusion due to its superior chewing efficiency. Many clinicians contribute to the concept of lingualized occlusion. Pons proposed non-balanced lingualized occlusion. Pioneer proposed the use of 30-degree anatomic teeth, which already discussed, which was later reshaped to obtain lingualized occlusion. This scheme had complete intercuspation without any occlusal contacts. In the picture, you can see large palatal cusp, which directly falls on the fossa of lowers. So there is no interference while lateral excursion. And because palatal cusp is directly falling on the fossa, it has greater efficiency of chewing. Okay. It is termed lingualized articulation because of semantic terminology of American English, in which the inner cusp of the maxillary and mandibular teeth are termed the lingual cusps. British English, palatal cusp contact articulation. You can get question from this. Lingualized articulation, you will get, then it is a same term for lingualized occlusion. And in British English, there is they call it as palatal cusp contact articulation because palatal cusp is directly contacting on the central fossa of lowers, right? Then come to your monoplane occlusion. Actually, what does it mean? You can see in the picture, the monoplane occlusion is, plane of occlusion should be flat and parallel to residual alveolar ridge. You can see there is a flat occlusion. Re-establish the concentric contact as necessary by manipulating the mandibular posterior teeth. Make sure that the incisor guide pin maintain the contact with the incisal guide table when you have completed this step. While performing this step, make sure you do not alter the horizontal overlap of the posteriors. So this concept is similar to the, so you can see monoplane, basically it is similar to neutrocentric concept. The term neutrocentric denotes an occlusion that eliminates the anterior, posterior, and buccolingual inclines in order to direct the forces to the posterior tooth. And it is also helpful to prevent any kind of injury to TMJ. So there is no stress to TMJ if there are no compensating curves. No compensating curves. So it is kind of, you can imagine it is a flat, basically monoplane. There is no plane. There are no curves. Okay. The horizontal overlap of the posterior overlap should be at least 1/3 of the width of the occlusal surface and be sufficient to prevent biting of the cheek and corner of the mouth. We do not have to cover up this as we cover in normal occlusion. Okay, so we have to make it flat. Then come to your mutually organized occlusion, or we can say organic occlusion. So what do you mean? The shapes of the teeth are altered to have cusps suitable for the patient. The movement of the condyle determines the direction of the ridge and grooves of the teeth, and the mandibular movement determine other factors like cusp, height, fossa, depth of the fissure, concavity of the lingual surface. In organic and organized occlusion, the aim is to relate the occlusal surface of the teeth so that the teeth are in harmony with the muscles and joints during function. The muscles and joints determine the mandibular position of the occlusal without any tooth guidance. In function, the teeth are supposed to have passive role and do not influence or determine the path of mandibular movement. Otherwise, in normal occlusion, the tooth factor determines the mandibular movement. Like if the teeth have cuspal inclines, steep cusp tips, so we can determine these type of steep condylar guidance or incisal guidance with the help of proper condylar inclination and incisal inclination. But in this case, which we consider in normal occlusion, but in this case, the posterior teeth contact in centric occlusion only, incisors contact during protrusion only, and canine contact lateral excursion only. Okay, basically the function, the teeth are supposed to have passive role. They are not activate in all the movements. So concept is to observe. Right. There are guiding factors. As we all know, condylar guidance and incisal guidance increase the separation, which is